Welcome to the Vet Dental Show. I'm Brett Beckman. We've got a new episode for you this week, and we're going to be looking at dental charting. This is a very frustrating aspect of our veterinary dental service and general practice, and we're going to tell you how to make this so much easier in a short period of time. And this segment comes from our brand new periodontal course that is available as of right now, today. And up until Sunday, we've got 50 practices that will receive a special offer that I'll tell you about at the end of this program. So sit back and enjoy and take notes, because there's a lot of information here in this dental charting segment from the brand new periodontal course, Current Concepts in Periodontal Disease in Veterinary Medicine. I'm going to go over the main things that you need to remember just for your periodontal cases. And there's a lot of things that I want to go over as far as charting goes, and what you do specifically, and what can save you time charting, and what's necessary and what's unnecessary. So to start off, as we've discussed these two procedures, so what I would suggest is that you have some type of a combination of these two bundles with each of these two components to it as part of your service sheet, as we've mentioned. And so we can use these as a abbreviation for every time we do root planing and apply Periovide. So root planing close subgingival curettage is abbreviated with RPC and SC/SC very easily. And then hyaluronic acid, you can abbreviate HA. So that is your designation for the treatment portion of a periodontal pocket where you have bleeding and you've done the RPC/SC. Same thing with the bone graft and root planing open, RPO/BG, and then HA to use as the abbreviation in your dental chart each time you do these. And then this X here, this is what we utilize first from the standpoint of looking at what we're going to do from an extraction standpoint that we know just based on the x-rays. So just to give you an idea of how I approach this, you don't have to approach it this way, but this is a really efficient way of approaching your whole process of doing your evaluation on your patients. Once the technician has taken the x-rays, and in my case, my technicians know how to interpret x-rays, so they will actually mark on the chart the periodontal disease index, which we'll talk about in a second. So they're gonna mark on the chart the changes that coincide with the x-rays, and then I've got the chart that they've already looked at, and then I can look at those x-rays while they're cleaning and continuing their probing and doing their more detailed charting, as opposed to the x-rays themselves. So I've got that chart, and I'm looking at the x-rays. I haven't even looked in the patient's mouth under anesthesia. I'm called into the room. I grab the chart, go to the x-ray screen, and start to read those x-rays, and do so in the exact same order from the right maxilla to the left maxilla, and then from the left mandible to the right mandible, in that template every time, same exact way. And so we can do this very quickly. Go through, look at those x-rays, double click on an x-ray, enlarge it, see what the defect is or not. And if it's an extraction, I'm just going to place an X on that. And I'm going to go through that whole mouth and put X's on every tooth I'm going to extract. And then that portion of the procedure, I'm done with my evaluation. I will go back, obviously, and look at the pathology after the technicians have charted that. And then while I'm doing that, they're calling the owner and giving them the majority of the estimate. And so when we're done with that short process, we're ready to start the procedure. So those X's are over the majority of what we're going to do from a cost standpoint and from a procedure standpoint in almost every patient that we see, because as you guys know, with periodontal disease, the main thing that we're doing to treat the patient that has a significant impact is surgical extractions. So knowing that those are the most expensive and those are going to be the most time consuming, consequently, they're going to constitute the biggest portion of that estimate, we can very confidently give the client that estimate. And then if we need to add something later, we let them know that we're finishing up the fine tuning. And once the doctor starts, we may find other things as we get in surgically. We'll call you if there's any changes on that. Very effective way of doing that, very quick way of getting the majority of the charting done with the extractions that you're going to do just by using that X on the treatment side of your dental chart. And then we talked about furcations. So you're going to find furcations. They're not super common, but you're going to find them. They're not as common as periodontal pockets by any means, but you're going to find them. So you grade those 1 through 3, as we've already discussed. And then one other thing that we haven't talked about is gingivitis index. So GI 1 is mild, 2 is moderate, 3 is significant gingivitis. So again, very subjective, but you can use that to put those notations in the chart so that when next time this patient comes in, if we're not extracting those teeth, we can evaluate that based on what treatment we've done, based on the interval we've given for that individual patient, whether it be 3 months, a year, or whatever that might be, and see how much of a return to those previous parameters we have, or how much improvement we have in that amount of gingivitis that we're marking on the chart. So that becomes important with our periodontal reevaluations. So we want to make sure that we mark those when we're doing our charting. And then with the fact that we are extracting teeth, I can't stress this enough that there is no justification whatsoever to clean teeth that we're going to extract. It's a total waste of time to do that. We're trying to get this patient up and out of anesthesia quickly. So we want to make sure that we do everything as efficiently as possible, and taking the time to clean those teeth that are going to be extracted is absolutely ridiculous in my view. So I would strongly advise that you consider not doing that. You will have some teeth that are going to have a large amount of calculus that rides up above the marginal gum line, that if you take an extraction forceps and you crack that off, that's going to help you for sure with your extractions, but that's very quick. We're not actually getting down and cleaning. When we get done with those surgical extractions, everything's clean. We've got a new bone level that we've contoured after those extractions. So we don't need to remove that. One thing that I've had that is an argument, but it's not a justifiable argument, is that if we leave the calculus on there, we're going to alter our ability to interpret the radiographs. And that's absolutely not the case, with one exception. And I've had this a couple times in practice, and they've been in brachycephalic dogs where there's so much palatal calculus that when you take the radiograph with that sensor intraorally, you will superimpose that calculus over the root structure. But that's palatal because we're shooting vestibular to palatal. If we're shooting vestibular to palatal, we have coronal calculus. That coronal calculus is not going to be superimposed over the tooth roots. So again, those would be the only times, and I've only seen that a couple of times, that you want to remove the calculus before you take x-rays. All right, so that's, we'll go on from there. That's a little pet peeve of mine that I think is super important that I want everyone to understand. And then our charting abbreviations, the periodontal pocket depth is indicated by a P and then a number, whatever the depth of that pocket is. And we're not measuring normal pockets. We're not trying to take the time to place a designation on every tooth. The only pockets that we need to put on that dental chart are the ones that are bleeding when we probe. And we might have some dramatic differences between the depth of that probing for an individual tooth. So you can certainly justify putting different numbers, maybe 2 different numbers for a tooth that indicate the periodontal depth of that pocket. But at the same time, we're not probing teeth that we're extracting. There's no reason to do that. The designation that we're going to use for extraction that justifies the extraction is that periodontal disease index, or PD 1 through 4. If we've got a 2 through a 4, those are indications for extraction. We don't need any more information on that tooth. And the reason is we're not going to come back in 3 months or 4 months or a year and measure pocket depth. We don't care what the pocket is. We know we're going to extract it based on the bone loss. So use that and keep in mind these concepts so that you can make that process much less time consuming and think about it from that common sense standpoint and apply those principles in the practice. I hope you enjoyed that segment. That is, again, just a part of the Perio course that's available now starting today, Wednesday in May. This is Sunday, May 4th. I'm recording this. So 5th, 6th, Wednesday, May 7th. And this offer goes until Sunday if it's still available. And we are allowing 50 veterinary practices to purchase this course. And with that, at a huge discount, we are offering free 2 applications of PerioVive, which will treat about 6 pockets or 6 patients each. So 12 patients that normally would be $135. It is free for purchasing this course at a huge discount. So take advantage of this. This is only available for our podcast listeners and our email subscribers. So hopefully you'll see the value and take advantage of it and enjoy the patient results that you'll get as a result of using it. We'll see you next week.